There we go. Okay, so let's start. It is being recorded, so if anyone is late, then they can go back and listen to the beginning. So welcome everybody to Gender Plus's first webinar. We hope it's one of many, and we're going to work through some questions today. So we're here for the next hour up until 8 o'clock, and hopefully we can, my timekeeping is sometimes questionable, but hopefully we keep to time. So we are an independent gender service comprising of clinicians who have worked within the NHS gender services, either presently or in the past. So you may recognise us or heard of us. The three of us here have worked in GIDs. So why are we here? Well, we've come together as an independent practice to offer a timely, compassionate, very important, evidence-based gender service to young people and adults. So we're going to open up with some frequently asked questions that we've had, and then we will open the floor to any more questions. So please pop them in the box. Those can be asked anonymously if you would prefer. So we can't answer any questions that specifically relate to a patient, so we can't breach confidentiality. So please bear that in mind. So first of all, I guess you want to know who we are. So let's do some introductions, and as I've got the floor, I guess it's me first. So I am Paul Carruthers, and I am a nurse consultant, and I manage the Gender Plus Hormone Clinic. So previously to coming on board with Gender Plus, earlier this year, I worked as the GIDs, Gender Identity Development Service, lead nurse. So I oversaw the endocrine pathways for the country. And yeah, that was for 8 years. So who's first? Aidan, do you want to introduce yourself?
Thanks, Paul. My name is Aidan Kelly. I am a clinical psychologist and a director at Gender Plus. I have worked at GIDS for about 5 years, and then just short of 2 years at the Nottingham Adult Gender Service. And yeah, I'm excited to be here and be doing and can talk to you about Gender Plus this evening. Over to you, Claudia.
Yeah. Hi, I'm Claudia Zitz. I'm a clinical psychologist and also a family therapist, working at Gender Plus, and previously I've also worked in GIDS for about 10 years, and before that worked in CAMS services. So it's really good to be here this evening.
Thanks both. So are you ready to take the hot seat? I think I'm going to lead to start with the questions. So Aidan, I guess as our director, the first question should probably come to you. I think it's probably good just to sort of open up and talk about what we offer at Gender Plus.
Sure. Thanks, Paul. So we offer, I guess, the full array of services that you would expect from a gender identity clinic, including psychological assessment and psychological support. We do provide recommendations around hormone treatments, and for our adult, so over 18 patients, referrals for gender affirming surgeries. We also run a hormone clinic, which enables us to provide a fully integrated gender service. In addition, we offer I guess LGBTQ plus informed mental health assessment and treatment services, as well as neurodevelopmental assessment and support services for those up to the age of 18.
Thank you. So I know a question that we're getting a lot is how do we differ from the TAVI or from the GIDS model with, obviously it's out there that a lot of us have come from the TAVI and GIDS. So I don't know if you're able to sort of explain how we differ from the TAVI.
Yeah, I guess because we're an independent service, it means we can be more timely in our approach and also more responsive and have an individually tailored approach to the service users we see. And a bit like Aidan was saying, I guess we offer a kind of wraparound service. So we have a multidisciplinary team, and we can offer, in addition to gender support and exploration, we can also offer support in terms of mental health, as well as neurodevelopmental assessments, and of course, the kind of endocrine support as well. And I guess we do follow developmental approach, and we also kind of engage with local agencies if we need to. If I've forgotten anything, please feel free to add.
No, that's good. So the next question, and this term is a hot topic, isn't it, politically, especially with sort of lots going on around conversion therapy. But Aidan, I wonder, does Gender Plus take a gender affirmative approach to healthcare?
Thanks for that one, Paul. So at Gender Plus, I guess we start from the position that all gender identities are valid. We do not promote one gender identity outcome over another. Our aim is to support our patients in being able to explore all facets of their identity. To work with anyone psychologically, it is important to be respectful, compassionate, curious, and open-minded. I guess I know we believe in meeting the individual where they're at and helping them to move forward. In order to do that, our approach must be inherently affirmative, which essentially means accepting the individual for who they are and believing that their experiences are real. However, we also believe it's important to maintain a level of, I guess, curiosity to ensure that the individual is able to explore their identity in a developmentally appropriate way, without fear of this information being used, against them or to invalidate them, I suppose. So hopefully that answers that.
Yeah, I think, definitely. So I guess for people that are listening, I guess they sort of want to know sort of what the processes are. So Claudia, I don't mind if you would answer this one and sort of talk us through the steps about what would happen when somebody comes to Gender Plus.
Yeah, I guess when someone comes to Gender Plus, they can go on our website and fill in a referral form and then book in an appointment. On our end, a clinician reviews the referral information, and we also send out questionnaires to the person and possibly also carers. And that's just to build up a kind of holistic picture of the individual. When we meet, I guess what we do is we kind of ask what the hopes are from coming to Gender Plus, and sometimes also worries that might be around. And based on that, we develop an individualized plan with the young person or with the adult about future appointments, usually for under 18s. If they want to do a gender assessment, that's around 6 appointments. For over 18s, that's usually fewer appointments. Especially with under 18s, we work with the young person as well as the family and parents, carers. Again, so taking a holistic approach. For over 18s, we meet the individual, but we still think holistically, and where appropriate, we might invite a partner, also parents or family members, that would be discussed with the individual. And then also where appropriate, we might link with kind of other support networks, so that sometimes might be schools or mental health professionals to promote this kind of integrated working. At the end, so if someone chooses to have a gender assessment, I guess at the end we write a report that summarizes the meetings we've had, and we come up with a kind of shared decision about a plan of how to support the person we meet kind of going forward, and agree on the next steps. I think that's pretty much it.
Yeah, and obviously then one of those options might be that they come through to the hormone clinic, which when I've gone through these FAQs that have come, we're going to sort of answer those a little bit later. So Aidan, I know why we've all come together. We're hugely passionate about this area, and it's something that we're really driven to help improve, and everyone that's come together is really committed to the trans community. And I think what's good is of late that there are more independent providers popping up, which is great because everybody should have choice. those that want to, if they don't want to remain in the NHS, you know, there's lots of choices that are popping up there, and I think that's good. But I wonder, you know, especially because why we're here, why we differ from those that are on the market, and why somebody might want to choose to come to Gender Plus.
Yeah, thank you, Paul. I mean, I think what you said in the questionnaire is right. I think there is, I guess we come together as a group of clinicians with a kind of shared set of values, I suppose, in that we believe that it's kind of right and fair that young people and adults should have an accessible gender service, one that's kind of respectful and compassionate and holistic, I suppose. I guess what is unique, well, not necessarily unique, but I think is important about us, I suppose, is we're UK and Ireland, but I guess for this group, kind of UK based. So we're all kind of UK based and registered clinicians, and we have current offices in London and Birmingham, and potentially opening something up a bit further up north and perhaps in the new year. We are all clinicians who are either currently or previously have worked at NHS gender services, and so we've got cumulatively decades of experience between us in doing this work. I guess the knowledge, the skills, and the experience that comes with that feels important. And I guess the other big thing, I suppose, that will definitely, I think, make us unique actually is our kind of almost CQC registration. So we're on course to get our CQC registration hopefully by the end of this year, so in the coming weeks. And we've just, we've completed a almost 6-month-long application process, which culminated in a site visit and inspection kind of last week, and we're kind of we're awaiting the kind of outcome of that, and so hopefully the final kind of decision around our registration will be in the next couple of weeks, really. So that's a very exciting thing for us. We've got no reason to believe that we won't get it. We're getting very positive feedback, and so from CQC. So I think as a CQC, independent CQC registered service serving young people and adults, that will make us definitely unique in the UK.
Thank you. And yeah, we're really excited because we would be the first young person's gender service to be CQC regulated, and it's something that we've set out to aim for, isn't it, that we've got to have a regulatory body. So should we turn this around? Aidan, do you want to answer the question, or ask the questions rather, about hormones? Because I know that's always a hot topic, and I'm very happy to answer any questions on the medical pathway.
Delighted to turn the tables on you, Paul. Yeah. You're right. Hot topic indeed. Hormones. So let's look at some questions relating to the Gender Plus Hormone Clinic. So are Gender Plus prescriptions written by GMC registered doctors? Paul, can you answer that one, please?
Yeah, I can, happy to. So I am not a doctor, I'm a nurse and a nurse consultant, but I'm also a non-medical prescriber. So I don't know whether a lot of people know about non-medical prescribers, but we can prescribe everything that doctors can, as long as it's within our scope of practice. And as I said at the beginning, nearly a decade of experience working in gender healthcare. It will be me that will be writing the prescriptions, but they are exactly the same as any doctor written prescriptions.
Great. That's very helpful to know, Paul. I guess another common question and a hot topic, I suppose, for you is around whether you'll be prescribing puberty blockers.
Yeah, so where to begin with this one? So I guess yes, because puberty blockers are usually prescribed alongside hormones. But as a standalone medication, that isn't something that I will be prescribing. And the reason is Gender Plus Hormone Clinic are looking after young people post 16. So for most of them, puberty is usually complete. So it's not something that we're offering as a standalone treatment, but absolutely they will be offered alongside hormone treatment. And certainly with the trans females, for those that don't know, hormone blockers are routinely offered to switch off testosterone production while estrogen is titrated. And most people, if they choose that, would remain on hormone blockers until they had an orchidectomy, which is where the testes would be removed. Yeah. Does that answer that question?
It answers that question, and perhaps it maybe the three of us might want to think about why are we taking why is this position being taken? Why not prescribe puberty blockers for under 16s? Is it because we don't agree with it? I guess that was one of the questions.
No,
What does it mean? I guess, is it we don't agree with puberty blockers for under 16s?
Well, I think puberty blockers can be really helpful for under 16s, especially if someone is in the midst of puberty. I don't think I agree with the approach where it's mandatory to be on puberty blockers for a certain period of time before someone goes on gender-affirming hormones, especially if they have completed puberty. So, and clinically, I think when I worked in GIDs, I have found it I've witnessed it being really useful for young people. And also, contrary to what many people are saying, sometimes puberty blockers has offered a time to think and explore, and some young people have come off puberty blockers as well, whilst the majority probably stayed on and went on to gender-affirming hormones. So clinically, I can see it offers lots of benefits. Yeah.
Yeah, no, I agree. So poses the question. So clinically, it's useful. What might be, I guess there's the wider picture, I suppose, isn't there? And maybe there's the political pressures and context that exists. And I suppose like us acknowledging that we do see them as clinically useful at times, for, in the right situations, but also aware that we want to get ourselves established and get ourselves, I guess. Established on a sure footing, really, and it feels sadly that that's quite a hotly contested area, and to try and take a first step in this field, I guess, in independent practice, it feels like starting from 16 plus is the safest way to do that. But it doesn't mean that we don't agree or don't see a value in blockers for under 16s.
I'm just wondering if it's useful to bring in one question from the audience, which is, if my 10-year-old has a gender assessment and it confirms gender dysphoria, how will you be able to continue to help and support him, and can he access puberty blockers through you?
Yeah. Well, I guess perhaps that links to what we've just been talking about, and it's unfortunately, I suppose that's not something at the moment that we will be able to offer, really. Although we do see how that could be certainly useful.
And we would still be able to carry out an assessment with the young person and think of further therapeutic support to help a young person and family navigate the process.
And I guess just to say that I agree clinically, blockers were probably the most prescribed drug that I did in GIDs, and the same as Claudia, I saw the benefits. But as Aidan said, as we've come together, we want this to work. We're really passionate about what we can provide young people. And I think for us to get off the ground in the political climate, as sad as it is, I think working with 16 and over, I think, is where we need to begin, and we will see where that develops as the future goes.
Just while we're looking back on some of the other questions before we progress, I wonder if you, I don't know, the question for you, Claudia, around what do you mean by the developmental approach?
Yeah.
If that feel able to answer that.
Yeah, I guess when we work with a young person or an adult, we think about the life stage that they are in, and I guess conversations and our thinking with the young person might be different if they're 12 and they're at home and they're kind of dependent and supported by parents. So we would want to make sure we acknowledge that and take that into account when we think about gender. And the conversations we have will be different, or the way we ask them will be different if someone is, I don't know, in their early 20s to when someone is 12 or 15. So that's kind of roughly what I mean. with a developmental approach.
It's really helpful. That's really helpful.
Mm.
Shall we do another one for you, Claudia? I think there's another question here that asks, if someone came to Gender Plus who is already on hormone treatment and blockers through another service with partial shared care with their GP, would they need the full 6 sessions of assessment with Gender Plus?
I guess they would still need to have the agenda assessment with Gender Plus and go through our MDT as well. But of course, we take previous assessments and reports into account, and but we will approach that on a case-by-case basis. But the likelihood is that it will reduce probably the number of appointments.
Okay.
Yeah.
So that means that it is possible to potentially switch from one provider to Gender Plus.
Oh, yeah, sorry.
No, that's okay. It's related. Yeah. So then I think this one's for you, Paul, if you're ready for this. How does Gender Plus's approach to hormone provision for adults differ from your approach to providing care for under 18s?
So, as we mentioned, we're sort of looking after 16 to 25-year-olds. So for the 16 to 18-year-olds, and Claudia's just explained it beautifully about the developmental approach, and I take that approach with hormones as well. So I would take your young person through puberty. So the pubertal hormones would be prescribed at a lower dose, and it's taken over a slow period of 2 years. So for those over 18, can typically access higher doses of hormones. But for those under 18, we would follow a pubertal induction regime. So very similar to what I did in GIDs. So the dose would begin at a fairly low dose, which would be the same as anybody who is cis going into their puberty. And then every 6 months, based on blood results, of course, and safety, then I'd be able to up the dose. And usually by the end of the 2 years, we've taken them through their full hormonal regime. So if you're over 18, then typically that can happen a little bit quicker. So that is typically the model that I work to, but everybody is very different and everybody responds to hormones different. You know, that's the beauty about us as human beings. And then also just going back to the last question about people transferring over, I think for me to access them into the hormone clinic, they have to go through Gender Plus. I think that's the beauty of us, that we're fully integrated. There's a really good model of the psychosocial support that work alongside me. I'm not a standalone endocrine clinician. And I really value the experience and expertise of the psychosocial clinician. So typically a young person would need to come through an MDT, a multidisciplinary team meeting, where an agreement for referral is made. And that's for every young person to come through hormone clinic. So if they have been to another provider, that would still happen. So they may not have as many as 6 sessions, they may only need 1, but then they would go to an MDT. The agreement would be made whether they would come through to see me, and then I would take over their hormone care from that point.
Right.
Do we want to cover costs? Because that was one of the questions asked as well. How much is it?
Very important.
Who wants to do it? I'm going to leave that one to me. I guess, there needs to be, totally transparent and honest about this. I guess offering such a comprehensive holistic kind of package of care, I suppose, does come with a cost, and we are very aware that accessibility was part of why we set up, because we didn't want to work in services that had many years of a wait, and sadly, I suppose that cost is a barrier for some people. So we do absolutely recognize and acknowledge that. So as in terms of the psychosocial, the initial, if you're coming in kind of from scratch, having not been on any treatments elsewhere or anything else done, if you're doing those six assessment appointments over 6 months, they cost £275. So there's 1 per month, so 275 once a month for 6 months. Of course, there's always individual difference that might be a bit more or a bit less, but usually I think 6 is a pretty good benchmark. For then, if the decision at the end of that 6-month process is then that kind of a referral into the gender plus hormone clinic is deemed appropriate, then your clinician would take that referral to an MDT meeting with many people in it, but definitely including Paul as the kind of lead for the hormone clinic side of the service. And if that referral is then accepted in that meeting, then you would receive a letter inviting you into to book an initial appointment, and it would give you kind of details of what would be required in terms of bloods and medical history. And once you have those in order, you'd be able to book a first initial consultation in the hormone clinic, and that also would cost £275. In that clinic appointment would be your nurse consultant, but also one of the psychosocial team. So I guess very much holding in mind the holistic needs of the young person, so or young adult. And so your endocrine needs would be considered in that point, but also your kind of psychological and social needs as well. And so once that consultation happens, and if the decision then at that point is to kind of issue that first prescription, you kind of you're starting on a more or less a 2-year journey of titrating up and building you up to a kind of stable dose or kind of full established dose of hormone treatment. And you would tend to, everyone's different, but you would tend to have 6 monthly reviews over that 2-year period. Again, with endocrine and kind of mental health, psychological related reviews in those review appointments, and before eventual discharge at the end of the 2-year process. But that the kind of the cost of that kind of being on the gender affirming hormone pathway is £80 per month. And what that £80 per month covers is all of those 6-month reviews, any interaction and follow-up needed with, in terms of liaison with GPs, interpreting blood work, potentially even supporting with, sometimes some of the older people might be taught how to maybe self-inject or these different sorts of support, I suppose. It's a subscription-based fee, I suppose. There is a step-out point at the end of each 12-month block. I suppose if someone at the end of the first 12 months decides to go elsewhere or do something else, then that's fine. They can kind of discontinue the subscription at the end of the 12 months. Or as what will be the case from the majority of people is that at the end of the 24 months, they will be fully established on hormone treatment and usually discharged back to the GP at that point. I guess the things that the fees don't include, I suppose, are any kind of prescription costs. So for example, if your GP isn't willing to do shared care, i.e. issue NHS-based prescriptions, then there would be a fee that you would need to pay to the private pharmacy, for the private prescription to the pharmacy to cover that cost. And I think that's the main big, or if the GP won't even do bloods or anything, then you might have to pay to get your bloods done privately as well. And so so I think so, it is that's the breakdown of the costs and what you get for that, really.
Thanks, Aidan. I'm just aware some of the questions that are coming through are relating to this topic, so I wonder if we should just answer them now. One is, well, what do we think the likelihood is of GPs working with us under shared care?
Yeah. Will I go? Yeah. I think it's positive, and I think sometimes, unfortunately, GPs can be a little bit apprehensive about the 16 to 18-year-olds. Over 18s, I don't see it being a problem. I've devised shared care, and I think when we get our CQC regulation, as we mentioned before, we'd be the first young person's independent gender service to have it, and most GPs and NHS services want to work with other CQC providers. So I think it's positive. And in terms of communicating with GPs, it's not a typical independent service where you just see me, I write a prescription and I say goodbye. I think that's the beauty about the subscription model. You have me on tap but not after 5 and not on a weekend. And I'm very happy to liaise with your GP, as are the members of the psychosocial team. If there's any meetings around your child or young person or young adult, we're happy to engage with other professionals. And what that might look like practically is me speaking to your GP, speaking to the practice manager, reassuring them about the prescriptions and offering any training that they may require as well in terms of giving the medication.
And it might just be helpful to add there, Paul, I guess through my experience of within the last few weeks, I have a couple of, young people who are under the age of 18 who I'm, come to the end of assessments with at the moment. And they have gone back to the GPs, and the GPs have said, once they get their CQC registration, then I'd be happy to do shared care. And so obviously it's down to GP discretion, but I guess initially the feedback is positive, really.
Just because you mentioned the age of a young person and when they can do the assessment. So someone asked if we would see 15-year-olds to do an assessment so that they can start kind of accessing medical treatment at 16. And yeah, so we definitely would do that.
Yeah, I think we see even people even younger than that as well.
Younger. Yeah, that's true.
We believe, I suppose, that the assessment process in and of itself can be helpful to make sense of and understand a young person's situation. And actually we can see distress, at times kind of being more manageable. It doesn't go away, but more manageable through the assessment process. Assessment sounds like a bit of a horrible kind of education, school-based word, but actually I think it can be quite a positive, engaging, collaborative, supportive experience, really.
Yeah. I think in the... Sorry. Oh, God, no, you go for it.
Oh, so there was a question about Gender GP, and if someone is on hormones already through Gender GP, how does that work? I imagine if they were to transfer over to Gender Plus.
Yeah,
that's like a full question, I think.
Yeah, happy to take a transfer of care. They would, as we said before, they would have to come through Gender Plus and have at least one meeting with a Gender Plus clinician and then follow the referral process to see me. And I would be happy to take over prescribing. There's a few stipulations there. So I would need evidence of baseline blood results, which usually would be taken before any person starts on hormone treatment. So that shouldn't be a problem. So as long as I've got evidence of that, then that's absolutely fine. And then I think someone was, when Aidan was talking about the subscription model, somebody asked about how would that look like if somebody was already on treatment. So typically, because of the way that the hormones are titrated, it is 2 years, which is why we offer a 2-year subscription model. But if somebody is already on hormones, then we would offer a step off point at 12 months in. So it would be very much an individualized approach. We wouldn't carry on seeing somebody if there was no need. So to answer the question, yes, we would take a transfer of care.
I think, is there a question around kind of locations? Where are we based? There's a question around whether there's a Leeds option. I don't know, Paul, that feels like another Paul question. Is there a Leeds option?
Well, I live in Leeds, so it would be useful.
We're hoping for one.
We are definitely hoping for one, yeah. So to get going, our main office is in Birmingham. So just to point out that there would only be one face-to-face appointment required, and that's the very first appointment with me. So in order for me to take consent with the young person or young adult, then I would like to see them face-to-face. That's really important for me as a clinician. So they would be invited to Birmingham or potentially London. Moving forward, sooner the better for me, so I'm not getting the train to Birmingham. We would like to have a base in Leeds as well, absolutely, but to begin with, it will be Birmingham.
Good to know, Paul.
I think there was a question also about in-person meetings, isn't it, on our website, and what that means. And I guess it's just giving young people or adults the option to meet with us face-to-face, because some people prefer face-to-face meetings and others prefer online meetings. For under 18s, we would want to meet face-to-face on at least one occasion if they want to undertake a gender assessment.
Yeah, right. What else do we have?
was just going to go back to the FAQs and then maybe come back to any questions that are coming in. I think there was a question here about whether individuals can use the hormone clinic as a standalone service, or do they need to use the Gender Plus psychological services? I think we might have answered this, but Claudia, I don't know if you want to add anything.
No, I think you answered that we are fully integrated. And I guess it brings the benefit of a comprehensive assessment, and this integration continues even when a young person or adult goes through the medical pathway. So yeah, so I guess it's integrated is the short answer.
Yeah. And it's something that I think stands us apart, and something that we're really passionate about, that the young person has that sort of wraparound care and that support throughout their whole journey with us. There's no standalone service or standalone clinician at all during their time with Gender Plus. Aidan, another question was, what support is available for individuals who might have complex psychological needs?
Yeah, I think that perhaps plays to the strengths of, talks to the strengths of our service, I suppose, and that we have that multidisciplinary team. We have consultant child and adolescent psychiatrist in the team. We have a number of clinical psychologists, psychotherapists, and so we have a kind of a neurodevelopmental assessment pathway. So an OT, occupational therapist, and the clinical psychologist that run the autism assessment pathway, and then the psychiatrist tends to do the ADHD related assessments. So I guess we've got everything that you would expect in a kind of CAMHS based service, really. And I guess because we're an independent practice, we're not confined by some of the restrictions that might be in place on NHS services, not just in terms of wait times, but also in the terms of the diversity of the services they can offer. They tend to be kind of uni service, so kind of one type of service that they offer. And so we have the skill base to offer these things. And if our kind of client group need these assessments or kind of treatment plans, whether it be mental health or gender related or both, then I guess we're in a fortunate position that we can offer that, really. So I think that's one of the real strengths in comparisons to when I used to be at GIDs, is that we would refer back to local CAMHS, and then people would sit around waiting for a long time, and everything would get a bit stuck. But actually we can be quite responsive to somebody's needs, and we have a team, a multidisciplinary team that's able to do that, really.
And I guess if someone is open to CAMHS and their kind of complex needs, then we work quite closely with CAMHS as well. And sometimes we offer the gender support that can get in the way sometimes of professionals thinking, oh, they can't work with a young person because there's gender, and they feel like they don't know how to do this. So we would make contact with CAMHS if the young person is open to them.
Great. So I think I've gone through my list of FAQs, so I think we'll open it to the floor. I don't know if there's any questions that have come through there.
There's another good one here. I think this is a Claudia type question. And what do assessments involve, Claudia? When we talk about kind of gender assessments, what do we mean?
I guess when I talk about assessments, I say it's not a test. It's really an opportunity to get to know each other and build a kind of therapeutic relationship. I often share what the kind of topics are that we would be thinking about together. So with the assessment, like I said before, with under 18s, we try and get involved, get parents or carers involved as well. And with over 18s, we can get other people involved if that's thought to be useful. But I guess in terms of some of the topics we would be thinking about, we're a gender service, so we will be thinking about gender, kind of how someone's gender identity has developed over time, and where someone is at the moment, and kind of what their future hopes might be. And I tend to think of gender, it might be a very individual, personal experience, but it's something you do in relationship with others. So I would also want to know how a person kind of navigates their gender in other contexts. So that might be in school, or for over 18s, it might be in education, in employment. and if there are any difficulties, where we can support with the difficulties. I would be interested to know about family and peer relationships, just because we know that people do better when they have social support, and again, think together if there are things we can do to support further. It's not always the easiest journey to undertake, so I would also be interested in mental health and how someone is supported and how they're generally doing. We also see quite a number of people who have who are autistic. I'm using that language because that's, I think, the preferred language. So we would think about kind of how that might impact gender, or gender impacts on autism, or especially I think when we think of medical interventions and how, if there are any sensory issues that might need to be thought through, especially when we think of some of the effects of medical interventions on that. And some other things that are more personal might be because often we see people who are distressed about their bodies. So, and if they want to access medical interventions, then of course that will often create kind of desired changes to a body, but we do want to know what someone's relationship is to their body. And then I guess if someone wants to go forward for medical interventions, we would think about, I mean, as kind of psychosocial clinicians, we are not medics, so we think very broadly about some of the effects and side effects. And we know that Paul later on will go through them in much more detail. But we would also think about what would it be like not, for example, to go on medical interventions as well. And generally, I guess and that's kind of what I'm interested in. And often, I guess, the person I'm working with, or the family members, will have things that they want to talk about more as well. Yeah. Are there other things you would add to that, Aidan or Paul?
That's
I think you answered that beautifully.
I mean, I just want to say for over 18s, I think we would still cover similar areas, but often, in my experience, someone's gender identity is more established, and perhaps it doesn't take so many appointments really to kind of, explore those areas.
Great. Any more questions? I think someone has asked a question. I know the language we're using, we're quite often talking about young people, but we are talking about our age group of 16 to 25-year-olds. It's probably something that's embedded in us as we're predominantly working with adolescents, but we do mean 16 to 25s. So would an over 18-year-old be able to access hormone prescribing as a standalone service without the therapeutic support, I think is the question. So I think something that we're really passionate about, and we've developed this based on national and international guidelines such as WPATH and EPATH, is having that psychosocial support. But absolutely, we can't make somebody have the psychosocial support if they don't want it. But typically, within an appointment with me, there would be a member of the psychosocial team. It would hopefully be your named clinician, but it might be another member of the Gender Plus team. But absolutely, if that person didn't want that person to be there, and I felt that that was appropriate as well, then they wouldn't have to be. But the model that we've developed is in our view, using international and national guidelines, is what we believe to be the best. And that would be for what Claudia's just described as well, as to why we believe having psychosocial support alongside their appointments. So if they want to, I guess to answer is they don't have to if they're over 18, but it's something that we think is best practice. I don't know if you two have anything to say on that.
I mean, I guess the only thing I'd add is, I suppose, even though it's wanted change, it's still change, I suppose, undergoing physical change. And we know that hormones interact with how we feel, our emotional state, and puberty. You just have to think of your teenager going through puberty, even if they're not trans, it can be a bit of an emotional roller coaster. And so kind of going through that might well be fine and great, but I guess it's that kind of mind body, I suppose, interaction. We see that holistic approach to health as being really important, and I think that's kind of spoken about in lots of areas in terms of gender healthcare and the guidelines around that. And so that's why we believe that's important. That's why we kind of start from that approach, really.
Quick one about if we have current shared care patients with, I think this is with GP. So not current patients, because we're yet to open in the medical hormone clinic, and that's, hopefully we're hoping to open in January. So no, we don't have current patients because I'm yet to see any, but absolutely we'd hope to have shared care with GP. We're really passionate about, we know we're an independent service, but we're really passionate about keeping costs down, especially prescribing charges. So where possible, I will liaise with your GP to try and establish shared care. I think this is for you two. How do you address the issue of young people who want to pursue a medical pathway withholding information during the assessment period if they think it might stop them getting access to hormones? And I know this is a fear of a lot of trans people online, definitely. So I don't know if you two are happy to answer that.
Who wants that one, Claudia? Do you want it?
I'll go for it, Aidan.
Thank you so much. Yeah, I mean, I guess the very nature of working in gender identity is that it's a subjective, internally held and felt experience. And so we rely on people talking to us and telling us about how they feel. We can't read their minds, make them, coerce them. Not that we want to, even if we tried to, we couldn't. I guess I think one of the good things about having worked with adolescents and teens for quite a long time is that I guess openness and transparency and building a rapport, a good relationship, being engaging, hopefully, demonstration that you care, you want the best for them. And people tend to respond to that because people tend to want the best for themselves as well. And if they can tell that someone's kind of on their side, working alongside them for their best interest, well, then you tend to get people kind of opening up and engaging in that way. I guess there's no blood test or brain scan or whatever that I can do to kind of to decide this thing. There has to be collaborative, and I guess collaboration is key. If someone is kind of not collaborating or feels like they're holding something back, well, then that would, I guess, be a cause of concern or worry. And I'd be trying to work out why that would be. What can I do to try to engage with this young person? Perhaps that's why, it would be important to, especially for the under 18s, to at least have some way of checking in with parents. And even if they're younger than 16, 15 or 16, then definitely kind of, checking in with parents, trying to understand from their perspective, is there a reason for this, or why might there be kind of a block or a holding back on something, really. So I guess that's I hope would be our one of our skills and our qualities, is that we're pretty good at kind of engaging with young people, and so that's kind of part of our kind of bread and butter around doing assessment process. Don't know if that answers it, or is there anything else you want to add to that, Claudia?
No, I think that was really well put, and represents my experience as well.
Thank you. Do we support with things like depols and passports?
Yeah. So gender marker, so like changing the gender marker on the passport, there's a letter you have to write for that, and depol shouldn't need a kind of gender. Anyone, whether they're trans or not, should be able to change their name via depol. So I think, am I right in thinking that they shouldn't really need our support with the depol part, but definitely with the gender marker on the passport, yes, we've written plenty of those letters. And I think, was there anything? It was those two things, wasn't it? And over 18s, I know my name's on the gender recognition certificate list. Is this? I'll share my views on the list, but sadly there is a process that people need to go through to get a gender recognition certificate in the UK over the age of 18, and they need kind of a letter from a gender kind of specialist. I know my name's on the government approved list, and I think there's a move to try and get some more of our names on that list as well in the coming year. So that would certainly be something we can help with as well.
Great. I think this one's probably for me. Do you follow the informed consent model? Absolutely. It underpins everything that I believe in healthcare and consent. And I developed the informed consent model in GIDs, and it was something that the CQC recommended as good practice. So I've taken that with me and made it even better. So as part of the informed consent model, young people will be invited to watch videos with yours truly, give them lots of information. They would, of course, have lots of information with their psychosocial clinician. Then when they come to see me in the appointment, we'll talk through quite a robust consent form. And in order for me to agree to prescribe medication, I need to believe that they understand the risks and benefits to hormone treatment. And without that, I won't prescribe. So that's what it means by informed consent. So the young person, and it may be that they've got some communication barriers, and we can work around that. You know, we firmly believe in our equality in this service. So there's many different ways that we can communicate with a young person. But fundamentally, I have to understand and believe that they know what they're signing up for to start on hormone treatment, which is what informed consent is. So yes, I do follow that. And if another question, if a 16-year-old, I'm going a bit quicker here because I know we've got 8 minutes. If a 16-year-old came without parental support, could we still prescribe? Tricky. So legally and under the Mental Capacity Act, 16-year-olds can consent to medical treatment. However, in Gender Plus and in the Gender Plus Hormone Clinic, we would strive to have parental or parental responsibility assent, so that there's a parent or a carer or another representative agreeing to treatment. We know that some young people have complex backgrounds, and that might not always be the case. If that were to be the case, then they wouldn't follow a typical pathway to see me. We would discuss them more as a multidisciplinary team in order to agree what we would think is in the best interests of that young person, whilst bearing in mind that they legally can consent. But it would be incredibly rare for a 16-year-old to come without somebody with parental responsibility. So legally and technically, yes, I could, but it wouldn't be a decision I would rush into. We'd have to explore that further and explore what the reasons would be behind that. So I think that's probably a bit of a politician type answer. So I hope it did answer the question.
I guess it's also based on young people. I mean, talking about this developmental perspective, they are often, they live at home or they live with carers and they depend on them. So, and we kind of know young people do better when they have some kind of social support, and that's why we would really need to think that through a bit more.
Yeah, absolutely. So I think question here, if a school or social services were questioning a young person's gender and being unsupportive of their identity, would you communicate with those services in order to support the child?
Yeah, I would say absolutely, and I would see that as part of my role. I feel really passionate about supporting young people, or adults, not just in the immediate environment, but also in other domains that are important in their lives. So I think all of us in Gender Plus would do that and advocate for a young person. And sometimes it's also about finding out what the concerns might be by the people who are working with the young person and trying to address that, and also educating and often bringing in the Equality Act can work wonders as well. Yeah.
Great. I think we've got 5 minutes. I don't know if there's any questions. Oh, here we go, another one. Can we provide psychosocial support for under 16s on referral from another professional if there was someone providing financial support when parents are unsupportive?
Under 16. So this person would be under 16 without parental consent, and somebody else is financially funding it. That's a tricky question. I suppose we would seek consent from a parent, especially for under the age of 16. I think that would be our kind of our position on that. I think in terms of parental responsibility, I think legally we'd be in a position there where we'd have to have at least one parent consenting to the young person being seen in the service.
Yeah.
I mean, that's also something that we would try and find out what is the barrier of a parent being involved, isn't it?
And try to address that, really. Yeah. So if there was, so often what we do, actually, I should say, is we often meet with parents first. And so before the child even comes to the service, a parent might want to meet with us to explore, what does this mean? What are you going to do? What's this process look like? And we would, we would be very open to doing that and trying to hear any worries, address those concerns, and try to work with that kind of anxiety that would be there.
Yeah, definitely. And I think, with everybody, I think, just to sort of summarize and wrap up, is that everybody is treated as an individual, aren't we? I think that's what we're really passionate about, is providing bespoke care. So hopefully the questions have been answered. Some of them are fairly generic, trying to cover everything, but we would absolutely work with either your child or young person, young adult, as an individual and provide what's best for them.
And just to add, because that was another question, we would also work with parents separately as well. Yeah. And I think we have got quite a lot of experience of that. Yeah.
Thank you. So if you want to find out more about us, you can find us at www. I'm always worried I'm putting too many W's in there, but the 3 W's.genderplus.com. And then we're also on Instagram at genderplus UKIRL. So you can follow our socials on there, and we'll keep you up to date, especially with regards to the CQC. And if you want to speak to any of us, then you can contact us through our website. So thank you so much for your time. I'm aware that this is going to be recorded and then shared widely for those that haven't been able to attend. So thank you. I don't know if Claudia or Aidan want to say any parting words.
Just thank you, and appreciate you taking the time to speak with us and listen to us this evening.
Yeah, thank you from me as well.